of terms like mistreatment.
I don't think I
And I'll
under.
put a link to the report in the chat as well. Sorry, go ahead.
Oh, I don't think I understood the question. Sorry. You were breaking up a little bit.
Oh. So Lenka, I think, noted that there was not a lot of discussion of obstetric violence. There was a lot of talk about mistreatment rather than obstetric violence, and
Yeah.
the reason for that.
Yeah. Oh, that's a great question. Thank you. So as a concept, I think it's particularly in the way that the Inter-American Human Rights System or the or some like UN experts have approached it. I think it's very important. It's a very important concept that allows us to understand that there's a system of that's basically patriarchy, that there's a system of gender stereotyping that's behind a set of behaviors that are violent because they are discriminatory and because they do have an impact in our well-being, right? So I do celebrate, and I think it's very important concept to use. I, however, also understand that something that has been missing from that is the recognition that there is something beyond just the interpersonal attitudes of paternalism, of sexism that are at play in that relationship between the provider and the patient that also highly contribute to the crisis of obstetric violence. And that is what I was saying, like we have, in some cases, no public health system, like in the US. We have highly privatized, under-resourced health systems that make it very hard for people to provide an experience other than actual like violence. And on the other hand, the reason we decided not to frame it from that is because in a lot of parts of the world, but particularly in Latin America, it's being used to criminalize uh, providers. It's being translated into penal codes that are trying to solve the problem by criminalizing providers. And what I was saying is that we actually think that that's problematic because as I said, ignores the system-wide problem. And because it's being also proven by like experts on sociology and anthropology of the law that criminalizing discriminatory behavior is one of the worst ways to actually change societal and cultural practices that are discriminatory. And again, not to say that these do not need to be addressed. I am 100% a feminist and convinced that we need to dismantle the patriarchy, but I'm also convinced that the tools to do that are not the tools of oppression. The people who tend to be actually criminalized by penal systems and punitive systems are usually those that are most marginalized. So that is why we chose not to frame it from that. But I want to make clear that I do think the concept has been very important in raising awareness and in understanding that there's a broad range of practices that pregnant people go through that are very violent towards their whole experience of labor and childbirth.
Thank you so much, Ale. Lenka does have her hand up. So Lenka, do you want to unmute and say something?
Hello, thank you very much for your explanation. If I may, like add my humble opinion to that, I think that the term violence, obstetric violence, is misunderstood because it's a violation of bodily autonomy during pregnancy, birth, and postpartum, rather than to derive it from the word violence as such. So using the term obstetric violence for me is essential because it explicitly names a form of gender-based violence that is structurally embedded in the reproductive health system, while the term mistreatment may describe the symptoms. The term obstetric violence addresses the root, the systemicity of that, the institutionalization of it. Yeah, that's the abuse of power, and I would rather see it as a word being derived from a violation of the bodily autonomy rather than from violence itself. And this is not just about clinical errors or poor bedside manners, as the Emma and what were the pediatricians or perinatologists who went together and claimed that it's better to use the substandard care or disrespectful care. And my adage to that is there is no such thing as care that's being done without consent. When you do care without consent, it loses the term care. It starts being violent on itself. So it's like, we avoiding the term for me just sanitizes the problem. Naming it obstetric violence is the first step toward ending it for me. So I'm wondering whether, opening the debate about this not being an attack on the professionals, that we also deny healthcare professionals by refusing to name obstetric violence with the obstetric violence term. We really deny them the opportunity to reflect, and heal and reclaim a more humane and dignified model of care. Because when the system normalizes disrespect, coercion, and it's hierarchical, and there is innate hierarchical control, that creates that toxic working environment. And you know what I mean? Midwives and nurses are often pressured to follow protocols that are totally harmful or are silenced when they try to provide respectful, evidence-based care. And doctors too may become desensitized or burn out in a system that rewards speed and control over empathy and autonomy. So I think that naming it's not an attack. It's a path to professional integrity, safety, and systemic improvement. That's why I really, really fight for using the term, because it's not an attack. And I would really see it as a term that simply really perfectly talks about the experience of those who were suffering it and who were subject to it. Thank you very much. And please don't see it as an opposition towards your saying, but I would just really love to open the discussion around that. Thank you.
No, I think we actually are in agreement. As I was saying, I think the concept is very important. And just to tell you, I was one of the earliest proponents of recognizing the term back when it was like crazy to even say those two words together. When I was at the Inter-American Human Rights System, I'm talking about, oh gosh, like 14, 15 years ago. I don't even know how long that was. It was a long time ago. And there was a case that I had to deal with of an indigenous woman and that suffered. And when I went and I said, let's introduce this concept because it's so important, I got the biggest backlash. And ever since, so my point is, I have been part of having human rights bodies understand the concept. And I love the concept. I think it's very important. I also understand that the way it has been understood and the way it has been used is not necessarily the best in some instances. So I agree with you. And I actually think that providers should embrace it because it would be a way to also reclaim more dignified conditions and better healthcare systems that enable them to provide that care without violence. I agree. But again, one is the concept that we use for activism, and another is what we should translate into laws and how we address it in terms of remedies. And that's my issue with it because it's being used. We have tried to solve for this problem by creating criminalization. And that's where I disagree.
Yeah. Thank you. Thank you, Alejandra and Lenka. And I don't know if anyone else would like to add anything onto that. I mean, I know that people are adding into the chat. Does anyone want to unmute and say something?
Hi, my name is Amory Collins, and I'm a midwife in the United States. And I absolutely tend to agree that not using the words obstetric violence is problematic. I think that that word absolutely needs to be used because people like myself, as a Black person in the United States, die at the hands, and that is violence. A lot of people that are of Hispanic um, backgrounds die at the hands of obstetrics. So, and we have very high morbidity rates. Those that are indigenous to the so-called Americas die at the hand of obstetrics, and that is in every country from North America to Central to South America. So I believe that not using that word absolutely can erase the people that have died at the hands of those that are supposed to be caring for them. It is just, it starts at the mistreatment, it starts at the silencing, and it ends in the death. And we cannot allow these people not to have a voice, not to be seen, not to be heard in their absence because of the pure violence that has been caused to their body by the educational system of obstetrics. So just because people don't understand and don't agree does not mean that we cannot push forward, does not mean that we cannot educate them and stay true to what is being resolved or what is coming after the resolve of their decisions to other people's body. And it is violence towards the autonomy of the person that is given birth. So I think that, and to also always include the LGBTQ2S community, those people, all of us, me included. I am here because of my mother, because of my mother, um, also a Black woman, been vehemently fighting my OB provider to do something after my second C-section, and not just to hear that, oh, this is normal. My kidneys were failing. I was extremely um, um, uh, I was extremely swollen all over. I was in the hospital for 7 days after I had my C-section because my body was not responding. And I had postpartum preeclampsia for 7 months. So as a midwife, I am caring for people so that way they don't have to have that experience. And I just want to say that it is obstetric violence, and we need to use those words, and we need to have everyone understand on every single level of that profession that it needs to be changed because the result of those things that the obstetrics do can lead to violence, does lead to violence, and does lead to death.
Yeah, yeah, yeah.
Thank you, Anne-Marie. Alejandra, did you want to respond to anything, or otherwise I would pass it to Lenka and then to Anita. Go ahead.
Yeah, I would just say again that as I said, I agree. And I've been a huge proponent. We were trying to see what were the legal issues. So that's again, I want to make clear why we didn't use it from that standpoint. Because what we saw is that when we do go down to a national level, the countries that have adopted those definitions have adopted them in ways that are actually not empowering to the patient. So to give an example again, the law on humanized birth in Colombia recognizes obstetric violence, But it's the same law that tells you that you have a right to humanized birth if the conditions of the health of the day of the dad. So again, it's one, not empowering, and two, it's often used to criminalize behavior. So what I'm saying is, from the legal point of view, why we didn't use it is because it was not helpful to understand what was missing. And what we saw was missing is that we don't have a right, legally speaking, to exercise our agency during childbirth and pregnancy. But again, I just want to clarify that I think the concept is super important and I still use it. And I think it's, as an activist tool, that's very important to make people understand what's happening. Yeah.
Thank you, Ale. Okay, so I'm going to call on Lenka and then Anita. And Lenka, I'm going to ask you, because I didn't before, to give a small introduction to who you are, because not everyone knows you. And then to Anita. Go ahead.
Thank you very much. I'm a CEO of the Association for Freestanding Birth Centers and alongside midwifery units in the Czech Republic. And I would argue that the term obstetric violence is not an activist slogan. It's a legally and academically recognized concept. And the term captures specific gendered patterns of violence that occur within institutional settings during pregnancy. And, it's if we were to introduce this double standard, because it is a double standard. If a person chased you through a park with scissors, threatening you to cut your perineum without consent, that would rightly be prosecuted as assault. Well, when the exact same thing is carried out every day by an obstetrician in a delivery room without medical indication, consent, or even explanation, it is often seen as acceptable, routine, or even necessary by the standards of the society. And this is a double standard. That's why I would argue that we need lawyers to be ready to introduce this concept and this term into the legal grounds, as I don't understand why, when you see it like that, this double standard totally reveals a dangerous normalization of violence in medical settings and reflects how deep the problem is, how deeply embedded the obstetric violence in our system is, because we cannot even name it, because consent, as you said, doesn't become optional just because someone is giving birth. And that's why I argue that it's not an activist thing. And, just refusing to use this term erases the structural nature of the problem. It basically it hinders meaningful accountability and systemic change, because naming it mistreatment or substandard whatever care, it reduces a pattern of gender-based violence to individuals' misunderstandings. And it's not an individual misunderstanding, it's a systemic thing. And that's a form of denial in itself. That's why I really am totally pro trying to pursuing methods how to get it into the legal reality. And I'm using frequently the double standard thing, explaining people how come that when you change the surroundings, change the environment, and you have two people, one with the scissors, one with perineum, and then, I'm not going to repeat it again because it's hyperbola, but what I mean. It's a dangerous normalization of violence, and we are introducing double standards if we are like, missing out the point. It is violence, especially with episiotomy as the most frequent iatrogenic intervention in obstetrics. I would definitely argue it's an obstetric violencing. We can have a discussion about manipulation. We can have discussion about those softer things. Let's frame them. But with episiotomy, I would definitely argue it's an assault. If you are not consenting to that, it's an assault. Thank you.
So again, I myself am responsible for having introduced that concept in the legal realm. So of course I agree. But what I'm saying is that when you bring that to the criminalization area, you have to be careful of what you're naming as the crime. And when we are defining obstetric violence, we are defining it as very broad, which it should be, because there's a lot of things that happen that are violent. I, for example, experienced what another colleague mentioned. I'm a Latina and I gave birth in the United States. And the first time I gave birth, the obstetrician was not even looking at me. She, because it was a woman, she would only talk to my white husband. I felt violated by that. Like I was not even there. Like she was just having conversations with my husband about what was going to be done to me. But so that's, to me, it's part of what constitutes obstetric violence. But when we criminalize all the spectrum of the behavior, what we're seeing is happening is nobody's going to jail. Nobody's actually going to jail. And we are creating a backlash in those countries that are making those broad criminalizations. While at the same time, in those same jurisdictions, having all these laws that actually say you don't have a right to choose. You don't have a right to informed consent. So this is what I'm saying, like we're not making the system make sense. We're making all these laws that are humanized birth, but end up being about protecting the vulnerable person and actually strip you of your agency. The same laws that are about humanized birth are having language that say, but you don't really have the right to choose if the doctor thinks you're not okay, if the doctor feels that you are at risk. So please understand my critique, because it's not about not using the concept or not recognizing it in law, which I have myself been responsible for doing, at least in the Inter-American human rights system. What I'm saying is that when you bring that to national laws, you have to be careful of what things you're criminalizing and what type of laws you're putting in place, because the reality, as I said, is that legally speaking, even in countries that have wonderful recognition of the right to respectful childbirth, as the report states, in those same countries, we have all these laws and regulations that are saying, but you actually don't have a right to informed consent, but you actually don't have a right to make autonomous decisions. So that's what I'm saying. Like we have to, what the report offers is a look into how crazy the whole legal system is, and how you actually, when it matters, you actually do not have these rights. In these countries, you actually have more rights to terminate than to exercise autonomy and choice. So that's what I'm saying. But I am not, that's why, legally speaking, again, I'm a lawyer, we didn't took it from that standpoint because of the way it's being bring down to the national level. But the concept is important. I am a defender. I think it's very important to recognize that it's part of dismantling the whole system of oppression. It's just we're missing some parts, and this legal system is not making sense right now.
I want to go ahead and pass this to Anita. And Anita, if you want to introduce yourself and then go ahead.
Hello, everybody. My name is Anita Budak. I am doula from Croatia, and I'm also one of the 3 core organizers of the European Doula Network. So this is has been my topic for 10 years. I am leading free program through my doula association, Human Rights in Childbirth, for 10 years. And we have educated around 3,500 women on this topic. And I would agree with Lenka that this is a deep issue, and I think that focusing on law is very superficial, because the problem that we are facing in Croatia is that the reason for the violations, and there are many, stem from, first of all, managing the floor, the system. It is very hard to be an obstetrician and a midwife and still handle how many women can you let into the hospital and deliver them. So the speeding up the labor, using the episiotomy and Cristeller that is constant. And, it's a lot derives from speeding up the birth, because they don't know how to handle more women, especially in big cities. And we do not have any other possibilities because we do not have home birth. So it's 0.1% of home births. So all women are need to face the system. The other problem that I see as a acting doula for 11 years is that feeling, looking at the risk at the birth goes through very human filters. I don't think that there is more traumatized group of people by birth than the birth workers. So all of them are very much human, and all of them are making their risk assessment through their own trauma and through their own problems. And we cannot ignore it if we want to make something shifts. Another point I would like to make is there is not only rights of women, there are responsibilities that nobody teaches them. The responsibility that they are active participant in their birth is theirs. And women usually are not aware of it. So when you start putting, these things to them as an information, many of them start to be more active in birth, use their bodily autonomy, which means use their bodies. And if you are not on your back, they cannot do the episiotomy and they cannot do Christeller. So we need to change the approach. And this is what I have noticed in 10 years of doing this free course that is actually a cross-section of civil and health education on birth, is that we started to notice that the midwives and doctors are starting to release the control, because more and more women that are coming and they're like not asking to move, but they just move and say, I am sorry that this is difficult for you, but this is how I feel. It became normalized. 10 years ago, nobody was giving birth other on their back. And now they are much more perceptive of it. They are much more in stress because of it, because generations of women gave them opportunity to learn that it will be okay. So maybe this is not something that you think you can do, but as doulas, we can really help women to push their boundaries. But first of all, we cannot disregard the people who are working in the system, because they're also witnessing violence. They're also being violated. I will just give you also one example. So in Croatia, the CTG, the continuous monitoring, is always. So it is not intermittent, is continuous. Do you know the reason? It's not because the doctor wants it or the midwife. It's because the legal person in the hospital says, if anybody sues us, we only need this long sheet of paper and we are free. So I see problems if we are putting into the legal language, because I don't think that this is a solution. Thank you.
Thank you, Anita. I just want to ask, because if Katie, did you want to chime in on anything? Because we haven't heard from Katie, I just wanted to check in. But
No, but it's been such a lively and engaging conversation. I'm so excited to hear people so actively
Okay.
engaged on the topic.
Okay. But no, I agree with you, Anita, because I think that it's something that we are really aware of. I think with the team at ICI that we've been discussing quite a bit is the trauma of the healthcare providers and how that plays an active role, and what types of resources need to be developed, and the systemic issues around the oppressive nature of the system, and the punitive nature of the system, and the punitive nature of the way the healthcare providers are trained, and how that really, how that also creates sort of a blame and shame environment that prevents them from even acknowledging the problems when they happen. and how do we really rethink making the safe space to even start to open up the conversation, which is, I think, something that Alejandra's work is really, and Katie's work is really helpful in looking at, the fear of litigation versus the need to bring all the healthcare providers to the table to talk about the trauma and the factors that are causing this problem to be persistent. Lenka, did you want to? Your hand is up, so I just want to check and see if there's anyone else, because there's comments in the chat, and there are some comments also about the case that's going on in Brazil, which we can summarize. Okay, Catherine, you also have your hand up. So Catherine and then Lenka, and then maybe we can summarize what's going on in Brazil. Oh, Catherine, you can unmute.
Here it is. Yeah. My name is Katrine from Norway. I am a midwife. I've been working as a midwife since 2000, and a few years ago, I founded the Birthrights Norway. I can see in Norway, we have a reputation of being a good country for birthing babies. And that is an obstacle for us because women are being mistreated here. It isn't really different from other countries. I hear hundreds of stories from women writing to me, calling me. We need to call it obstetric violence. I agree to that because it is violence, and this is what women are explaining. They call it violence, so we need to acknowledge that. And then what I experience as a midwife, I haven't been working in the system for about 15 years, 14 years. I have increasingly contact with midwives who feel that they are not being able to being midwives as they are taught to be because they are getting punished if they are following their autonomous the midwife, you know, the how to be a midwife and listening to women and respect women. They are being punished by the leaders and reported higher in the system. So their hands are being tied. And then this is in the end, women are suffering from this. And they are always arguing that we need to do things, we need to intervene because of the baby. And it's really difficult for the woman to say, I don't care, you have to listen to me. And we have a big discussion now because of women are birthing without midwives attending in more and more because they are not trusting the system and the midwives to you know, support them in the way they want to be supported. I see more and more that it's a misogynic system. We need to change it to get the respect back and to listen to women. And we need to. It's a lot about talking about the law. What happens in Norway is that midwives. It's more easy for midwives or it's to break the law in order to follow the guidelines. So this is what happens. They are following the guidelines because they are so afraid of getting punished and reported. And that's mainly why they are not asking for consent. That's mainly why they are doing things without informing women. So we have a big problem about the guidelines are more important to the authorities than Norwegian law. Thank you.
Katrina, that is very interesting as a point. I'm going to go ahead and have Lenka speak, and then we will see. We're a little bit over time, but we can keep going as long as we've got people here. Oh, Lenka, was your hand still up?
Yeah, was. Thank you.
Okay, go ahead.
I love both of those arguments, and I would love to have hours and hours with Alessandra to tell me more and reveal the deeper logic into that law argument around her, let's say, omission of the term obstetric violence. I just wanted to react that there is a term being used by Claire van Leven. She's an academist from Istanbul, from the Department of Human Rights Law. And she said that there is epistemic blindness within the judicial system, that it's being recreated by lawyers and judicial people because they don't understand the depth of the problem. They just don't see it as like Wagner said, you are a fish and you don't see the water around you you're swimming in. So by saying that, we really would love to, we people in the field, love to explain to the lawyers somehow meaningfully why do we need that term and why we do understand that the meaningful change will require us to care for those who have perpetrated obstetric violence. But just I'm not in agreement with that we should decriminalize them. No, we are not going to excuse their actions. We have to just recognize that many healthcare workers are traumatized themselves, overburdened, and they are shaped by the harmful system. But, the way out, it's not by, saying that it's not a way to criminalize them. It is a way. Strategic litigation often is the thing we need to do when we are implementing the change. Strategic litigation plays a crucial role, I would even argue, in challenging this blindness, and it creates a precedent. So it's not pointing finger. I would argue that it gives professionals and institutions a framework to understand how they may be unintentionally, I would argue, reproducing the harm. And they have to understand that they either stay a part of the problem or they become part of the solution. Yeah, thank you.
Well, then I think you would be very happy to know that I myself litigated one of those cases. And I'm now currently trying to help with the case that's happening in Brazil. So I obviously am a believer in that too. That's not where my a reservation lies. And something that Anita said actually reminded me, and this is probably the last thing I'll say, but reminded me of a case that took place in Colombia. We, at least to my knowledge, because I have not done an in-depth research on the latest 2 years of criminalization, but we have had one provider going to jail. And we don't even have specifically like that has a written in the penal code, but this judge, super well-meaning, had actually attended some trainings on gender. So she came with this she learned the concept. She was all excited about it. And she ended up sending to jail this provider that she was a doctor in the poorest region of the country. She was the only provider in that healthcare center. She would often see up to 100 people a day, pregnant people, and she had not even been paid. She was like almost a whole year of salary. And the woman that brought the case against her was someone who kept saying, she kept saying, come help me, like I'm in labor. But again, this person was seeing so many women at the same time. And she ended up being criminalized. She ended up going to jail. And what that caused was that nobody wants to go there. Like nobody wants to be posted there anymore because they are afraid that they are going to be criminalized. So again, I'm just seeing the way these things are being implemented, and I don't think that for how well-meaning that judge was, that she's actually done anything to help. And I just wish that we could both be firm in what's unacceptable and bring people to jail when they have to go to jail. Because again, I've been involved in cases, even in Kenya, of like blatant violence that should be punished. But the spectrum of what's happening is very broad, and if we don't take into account the conditions that are making it impossible to provide care with respect, the way that people are traumatized and fear litigation, fear criminalization, if we don't create systems that are really actually recognizing your right to exercise agency, we're being trapped in this game where they tell us that they are listening to us, but they are not, because we still have crappy healthcare systems and legal systems that do not even recognize our agency. So I just hope that we shift the conversation to make it about the power of ourselves to make choices, and of our right and the right of providers to have healthcare systems that are actually in line with our dignity and our right to health. And that's all I'm going to say.
Yeah. I just want to add, Alejandra, to what you're saying is what I'm seeing, and I don't have a specific case to refer to, but I'm seeing sort of just very broadly and abstractly that what's happening with the environment of litigation is that when someone is criminalized, the response is not for any of the providers to behave better or to try to get an in-depth understanding of the problems, but it is actually it is working against us. It is backfiring and it is being used as a justification. And Lenka, this is something that's happening in many countries where ICI is active, is that our ICI providers are afraid to implement respectful practices because they are afraid that they are the ones who are going to be litigated against, as is happening in Brazil right now. So the litigation is being used actually as a way to cause hesitation and fear around providers who are trying to do good work. And so we're not, if it was effective right now, and if criminalizing someone, I think, resulted in everyone getting a better understanding of what women's rights are and respecting them, then I think that we would all be 100% on board. But we are not seeing that. We are seeing it being used very often. And again, it's a misunderstanding even of some of the legal, what some of the current legislation is, but it's being used to justify, I don't need to give this woman her rights because something could go wrong, and that any errors in the delivery, what perceived errors, will result in litigation, will result in criminalization. So that's what we're seeing. Ronnie, you have your hand up, which you have not had your hand up yet. So I'm going to pass this to Ronnie Valenzuela in Chile. And please introduce yourself before you speak.
Hi all, good morning from Chile. I'm Ronnie Valenzuela. I'm a midwife. I have been a midwife since 2007. I work in a public hospital in Santiago, which is the capital, in La Florida Hospital. And actually, we are running now a study with ICI about the experience of the women. And so far, we haven't the final results yet, but so far, what we know is that women equals respect with information. They are kind of the same, okay? Same level. And of course, the term obstetric violence exists, and it is a felony. It is something punishable. If it's proven and if it goes to a trial and everything and it's proven, it should be penalized. But the focus that we are having now is that the more and the better that we inform women about what we can do, about what they can decide also, what they can ask for me, for myself, is the key of all of this. Because we are focusing on the consequences, and which are of course important, but we should move the focus on the prevention. And how to prevent this is educating well. And what I mean by educating well is because not all women and not all countries have the same level of consciousness to understand what they are being informed, right? We have different education levels, even within a country, and we have different levels within a region, and of course, we have more different in the world. So we also have to learn how to explain the things. And so, of course, I agree with all of you in the different points of view, but I think the goal that we must have now is to inform, because that's the only way that we can reduce obstetric violence so women can actually have the knowledge to ask for their rights and to know what should be done and not. Because sadly, we are not going to change the providers. It's some of them may understand, some of them may get better and get up on this train, but we will have also providers that are not going to change and they're going to continue being violent. So women should have to stand up in those conditions, but with the right information. That's what I wanted to say. Thank you all for listening.
Thank you so much, Ronnie. I think you really helped us to summarize a bit of the what we're looking at for the way forward. And I think that we almost need a whole additional discussion to talk about, like, what is the path ahead. I'm just going to, there's a lot of great discussion in the comments, and I'm sorry I don't have a chance to read everything out. Oh, there was one question that I said I was going to ask, and the discussion was going so well that I didn't have a chance, but I do want to ask Katie and Alejandra. I know that we discussed this. There was a question about why the UK was not one of the countries studied. I think that was not necessarily an intentional exclusion. I think it was more that you had to narrow it down, right? But could you just comment on the inclusion and the exclusion of different countries?
The inclusion of what?
The how the countries that were included in the research were selected, because there was a question about why the UK wasn't included, which is a question I know I have asked as well in the past because of the current situation there. But if you could just respond about how the countries were sort of narrowed down.
Yeah. So it was a combination of they were countries where we had been working on for some time, enough time that we had a familiarity with the situation, but also enough connections to validate the information. And because we wanted a range of different types of healthcare systems, populations, just to see how they would compare. And the truth is that it didn't matter. Like they were all countries with the same type of issues. Like they were all countries in which women and pregnant people were not actually legally protected to exercise agency during pregnancy and childbirth. Yeah.
I think we are at almost we're over an hour and 20 minutes now. So I think that we might need to close unless anyone wants to add any last comments. But I think that this has been such a fantastic and well-rounded discussion. And I'm really grateful that so many of the participants have stuck around for over an hour now. I know we've had people coming in and out. We do have the recording. And as Katie mentioned, we will be having an additional discussion. So there is the second piece of the work, which is around midwifery regulation and, women, which includes a lot of work done around women's ability to access midwifery care and midwives' ability to practice with all the systemic problems that we're starting to discuss today. So I don't think we have a date pinned down for that webinar, but that will be coming up later in the series in August or September. I don't think we've narrowed down the date with the speakers. But we will have Alejandra and Katie coming back with us for that discussion, which is a really fantastic review of, the midwifery care that is necessary in order to address some of the problems that we've talked about today. Sorry, I'm just trying to catch up with the chat and see if there was anything else that we needed to add. And I did put the link to the report. I will put the link again to the report from the Center for Reproductive Rights into the chat. So if you want to access the full report, if you want to read more about it, if you want to cite it, because it is fantastic work done by their team, and and the team is even bigger than everyone who is here today. Unfortunately, we don't have everyone with us. I'm just going to go ahead. So I will put the link to the report into the chat. Any last comments? Or Ray, did you want to say something?
Actually, I can't wait to listen to the recording because there's so much in here and there was so many pearls of wisdom and so much to it. I couldn't take notes fast enough. So thank you all so much, Alejandra. Great to see you and meet you and have this topic today, and everybody else that participated with such valuable information and support. So thank you so much.
And Alejandra, is it okay if we share the slides with people afterwards as well? Because I think the slides also are a really good summary for anyone who wants to go back and go through it. Okay, wonderful. So we will upload the slides for everyone. I want to thank you all for joining us today. Please feel free also, we'll get the recording up hopefully quickly, and then feel free to share this with anyone who wasn't able to join us today. I know we had more than 100 people register, and not everybody, I think a lot of people came in and out, so not everyone was able to stay for the whole time, but we'll send it out to everyone who is registered. And we are going to continue with the webinar series. We might not have full programming through the month of August because some people are going on vacation, so we might have to skip a week. But I will send out the list of the upcoming webinars for people and confirm those dates. But know that we will be continuing, and there will be webinars going on, through September, possibly into October. And so if you have any subjects that you would like us to also consider addressing, please feel free to reach out and let me know. My email address, I think you've all gotten many emails from me, but it's mtherrien, THERRIEN @ICIchildbirth.org. And just a huge thank you to Alejandra and Katie and for everyone joining us today.
Thank you. Bye, everybody.
Thanks, everyone.
There's so much going on in the chat. I didn't even get to go through everyone's comments.
There's a lot of great comments.